A 22-year-old male presents with painless, bony lumps around his knees and wrists. I am showing you radiographs of the knees. Please describe the findings.
The radiographs demonstrate multiple osseous excrescences arising from the distal femoral and proximal tibial and fibular metaphyses. There are both pedunculated lesions pointing away from the joints and sessile lesions with broad bases of attachment.
What is your primary diagnosis?
The presence of multiple bilateral osteochondromas with cortical and medullary contiguity is diagnostic of multiple hereditary exostoses.
What is the key radiographic feature that confirms these lesions are osteochondromas rather than other exostotic bone lesions?
The key diagnostic feature is the continuous transition of the normal bone cortex to the cortex of the lesion, along with direct contiguity between the host bone and lesion marrow cavities.
What are the two morphological types of osteochondromas, and how do they differ?
The two types are pedunculated and sessile. Pedunculated lesions arise via a narrow stalk and characteristically point away from the adjacent joint, whereas sessile lesions show a broad-based attachment to the cortex.
What are the common complications of osteochondromas that can lead to clinical pain?
Complications include impingement of adjacent nerves or vessels, tendon friction, fracture of a pedunculated stalk, development of an overlying adventitial bursa, and malignant transformation.
What is the risk of malignant transformation in multiple hereditary exostoses compared to a solitary osteochondroma, and what malignancy develops?
Malignant transformation to secondary chondrosarcoma occurs in less than 1% of solitary lesions, but increases to approximately 1 to 5% in patients with multiple hereditary exostoses.
What radiographic and magnetic resonance imaging features suggest malignant transformation of the cartilaginous cap in an adult?
Suspicious features include new pain, growth after skeletal maturity, and a cartilage cap thickness greater than 1.5 to 2 centimeters measured on magnetic resonance imaging.
Finally, what are your clinical management recommendations?
I recommend clinical and radiographic monitoring. Surgical excision is indicated for symptomatic lesions causing pain, mechanical limitation, neurovascular compromise, or showing growth after skeletal maturity.